It is indeed a pleasure and a privilege to be invited to give this guest lecture at the 23rd Annual Conference of the Indian Society of Anesthesiology and Neurocritical Care. And may I extend my deepest gratitude to Dr. Indranil Ghosh for communicating with me and facilitating this. So I would like to share my slides. So over the next 20 minutes or so, I'm going to briefly discuss my personal experience and what we went through at the height of the COVID pandemic that hit us recently in the recent past, where absolutely nobody is being spared at the moment. So it's titled Neurocritical Care Amidst COVID-19. So I'm an emergency physician by profession, but have much involvement in critical care medicine in my country. Emergency medicine is a very new specialty in our country, but we're just forging ahead with every opportunity that we are given. So very briefly, background about myself. So I had the fortune to attend this very prestigious institution, which is your own institution. This is the All India Institute of Medical Sciences in New Delhi, where I did my undergraduate studies way back in 1990. I graduated in 94 and returned to Sri Lanka in 1995 after my internship. And ever since then, I've been practicing clinician in my home country. So Kolkata and Colombo, there's a straight air link. This is an open invitation to any of you who are happy to visit our beautiful island nation. Please get in touch with me if I can be of any use. So it's a fair distance, but with the current global pandemic, I know it's a bit difficult to make air travel. So we had to resort to modern technology. I'm very much involved in the Sri Lankan Society of Critical Care and Emergency Medicine, and I'm now currently involved with our own college, which is very new. So that's a bit of who I am and where I'm from and where I'm practicing. This is where I worked. This is the Neurotrauma Center of the National Hospital of Sri Lanka, which is based in Colombo, which is our capital city. This is actually a dedicated neurotrauma center because, as you are fully aware, our Southeast Asian countries with very high population density, with not the best of public transport, we get a large load of motor vehicle accidents. And this is a tertiary care center that looks after neurotrauma patients. It is a fully fledged institution with is self-sufficient in providing neurocritical care, neurosurgery, rehabilitation, and even ward-based management. We are well equipped. We have approximately 60 critical care beds, including 30 intensive care units for the neurotrauma patients. We are well staffed with 6 full-time neurosurgeons, 5 neuroanesthetists, and 2 neurointensivists. And I was the first and the only emergency physician who mans the emergency treatment unit of this very impressive building. We see about 2,500 trauma cases per year. And with the COVID, the numbers obviously have changed. It is less in number because of various reasons, as even during my talk, I would elucidate too. So SARS-CoV-2 took us by storm, so to say. It became a global pandemic in 2020. Sri Lanka was kind of spared initially. And our very first case of confirmed COVID-19 was this Chinese tourist from Wuhan. This was in March of 2020. And we were extremely happy, as you can see, once she made a full recovery and was discharged. But of course, things that followed is pretty grim. The worst, obviously, was the Delta variant that took us by storm. No one was spared. All the neighboring countries of India were affected, and Sri Lanka was no exception. And unfortunately, Colombo and the suburbs of Colombo in the Western province was the worst hit. and we had to take a brunt of the critically ill and the severe COVID patients presenting to our hospitals. So in this context, it was it was not unexpected that even the trauma patients following neurotrauma would present to us with incidental infection, because the community spread was quite profound. So what we were faced with was that even though stringency measures were taken a little delayed, we went into lockdown. That kind of drove down obviously, because people were kept indoors, were not traveling too much, drove down the number of motor vehicle accident related neurotrauma. But on the other hand, it led the way to more increased domestic violence, falls at home, people trying to do it yourself, repairs on their roofs, taking advantage of the time at home. But it led to a kind of a surge in that element of trauma patients. So all in all, what we found was that we were still getting neurotrauma patients, but we were getting neurotrauma patients who had a screening antigen test positive, which meant we were faced with this problem where we had healthcare worker anxiety and phobia because of the nature of the transmissibility and the infectivity and the virulence of this viral infection, which kind of led to a bit of patient neglect. And obviously, us being a tertiary care center, we were not in a position to ensure patient care, neurocritical care, because ourselves, we were not too sure how well we can do it. So there are many challenges with SARS-CoV infection and neurocritical care, obviously, because if you do get the severe or the COVID pneumonia patient suffering brain insult, management would be a nightmare, because we have to deal with patients with altered level of consciousness. We need to therefore secure their airway, and everyone knows that these are high-risk procedures because they are so-called aerosol-generating procedures. So anyone involved in providing neurocritical care under these circumstances was at risk. Then the mainstay of managing COVID-19 in the severe and the critically ill form, the two kind of evidence-based measures, that is the steroids and anticoagulation, obviously are contraindicated in our group of patients, especially trauma patients, traumatic brain injured patients. So this obviously was a real challenge as to if we were to be faced with this category of patients with the comorbid of COVID-19, which is the severe or the critically ill COVID-19s with neurotrauma, it was going to be a horrendous challenge. But what we did see was mostly incidental COVID infection, mildly symptomatic patients presenting with neurotrauma. And what was the obstacle there for us was, providing the usual neurocritical care that we would provide these patients in our institution because of these issues that we had to address. One thing foremost was our own staff members, our colleagues, even myself initially, the anxiety and the phobia surrounding the COVID infection, because Delta variant was not sparing anyone. And mortalities were high. The severe and the critically ill numbers were high. So we felt we were at risk in managing our patients. So we had to do something about it. We needed to train ourselves about safe clinical practice skills. So that was from top down. It entailed all the specialists to our senior medical officers, junior medical officers, our nursing staff, our intensive care staff, our allied health, sort of the radiographers, the chest physiotherapists, everyone who plays a huge role in managing neurocritically ill patients had to be spoken to, had to have simulation sessions, and we had to start from scratch basically to ensure that we have our own safety concerns looked after while providing the optimum care for the neurocritically ill patient. Similarly, we had to create a critical care unit that was capable of maintaining that safety, where we could optimally manage our neurocritically ill patients in providing, intensive care, such as invasive mechanical ventilation, close monitoring, and ongoing, suctioning, chest physio, all the things that entail high risk for aerosol generation had to be provided for our patients to ensure that they get the best care while not compromising at all and still being safe for the healthcare workers. So this was a challenge, and this had to be overcome. This had to be overcome very fast because it appeared that the Delta variant was raging on, and more patients were presenting to us with infection, but with neurotrauma as well. So paramount for us was to prevent patient neglect. There were instances where we had to transfer out neurocritically ill patients who needed neurosurgical intervention to COVID care, critical care units, which had no capability of managing them. And that was absolutely unacceptable. And from a perspective of a tertiary care center, it was absolutely unacceptable. So that led us to make the transformation in a short period of time. So personal protection obviously was important, and myself, my staff, and my entire crew had to kind of be taught about personal protection. We had to provide them with the necessary equipment. We had to ensure that they understood the very essence of it being a personal protective equipment. That means it is up to you to protect yourself. But having said that, we had to also provide them with the standard of equipment that would ensure that carrying out high-risk procedures in our patient category would be a certainty. So we had to resort to a bit of improvisation. As you can see, the scuba gear, which came in so handy, and that's myself really donning it. Because to carry out intubation, to insert central venous catheters, sometimes the standard recommendation of goggles and face shield gets in your way, and it can compromise your ability. But this particular device was absolutely fantastic. It ensured safety for me and did not obscure my vision in any way. So certain things, certain accepted innovations were practiced in our unusual situation where we had to adopt ourselves to manage our patients. Similarly, we had to do certain rethink and stick to protocol, especially in intubating our patients, because as you know, the majority of neurocritically ill patients do need to have a secure airway, and invasive ventilation is always one of the methods. So that neuroprotective ventilation is more or less a must in most of our patients. So there was no escape for us. So we had to rethink our strategies, be more systematic in our approach, formulate protocols, guidelines, and ensure that every member of the team would abide by them for their own protection and to ensure that our patients are not neglected and do get the optimum care that we always provide. And there was our duty was to overcome this horrendous pandemic situation and ensure that we continue the care. So we had to, formulate our own protocols and guidelines based on accepted recommendations from all these accepted kind of standard protocols from many of the international organizations. So we adapted whatever was more suitable for us. We did have to upgrade our equipment in the form of video laryngoscopes had to be purchased. The government, as you know, Sri Lanka has a free healthcare service. We do not levy any charge from our patients. So the government has to kind of support the healthcare services with a lot of financial aid. And at this kind of unprecedented event, it is a huge burden on the economy. So we did have to resort to, raising our own funds, formulate a fund drive, and, kind of supplement whatever that we needed for ourselves to be safe and to provide the optimum care. We had to fund from sources, and there was an overwhelming response of people willing to do that, and that in itself made things quite easy to deal with a difficult situation. So my unit has 10 beds and with 8 ventilator beds. So I'm able to, so it is more or less a combination of a ED ICU like setup where I can initiate emergency management and sometimes, even continue care depending on the availability of my disposition. If intensive care units are full, I'm able to, supplement that care as well. So I had to completely revamp and redesign this unit. We needed physical barriers between the infective area and the non-infective area. We had to create an area for a longer dwell time, which should be non-infective. So, and also we need to come up close to the patient so that we have good visibility. We can maintain the monitoring from the non-infective side. And we generally resorted to about a 2-hour dwell time in the infective area. So our critical care nurses had to regularly change over. Myself and my doctors used to dwell mostly in the non-infective area from a physical barrier so that we were up front and close to our patients. And if the need arises, we could always don our personal protective gear and go in. So that took a bit of training. It took a lot of labor to restructure and redesign. And one of the other main concerns was the ventilation. Because we had common air conditioning ducts for the entire area, it had to be separated out. We had to introduce a negative pressure system, which was quite a costly exercise, where the negative pressure would take out the circulating air and then vent it out through a HEPA filter, which is a large HEPA filter, to ensure safety all around. And we had to kind of spend a lot of time refurbishing, but eventually we got things going and the unit was functional within a short period of time. So as I said, paramount for us was that in spite of the COVID pandemic, in spite of the horrendous Delta variant surging through in numbers, we had to ensure that optimum care was given to our neurocritically ill patients. The map of Sri Lanka that you can see and all the dots are all the COVID care centers that are spread out throughout Sri Lanka, but the neurotrauma center at the National Hospital is the only apex center to manage neurocritically ill patients. Of course, we do have neurosurgical capabilities in most places around our country, but we get a gamut of referrals coming to us as well. So it is absolutely important that we adopt ourselves to the situation and ensure optimum care. And I cannot overemphasize the commitment of my staff, my team members, my junior doctors, my senior doctors, my senior nurses, my junior nurses, and all allied healthcare providers who chipped in, who got on the bandwagon with the intention to provide the optimum neurocritical care to our patient population. So in summary, SARS-CoV-2 infection really posed a lot of challenges to managing neurocritically ill patients in our center. So neurocritical care had to be provided without a break in spite of the raging Delta variant. We had to ensure that patient neglect could not be tolerated. So it was essential that we embark on this transformation of care model where we could allay fears of our healthcare workers and create safe areas to manage these patients. And that entailed a lot of hard work. We had to train our staff. We had to redesign our work area. But ultimately, it was teamwork that was successful in providing the optimum care to our patients. So thank you very much for giving me this opportunity once again, and may I wish the Neurocritical and Critical Care Society, Neuroanesthesia and Critical Care Society of India all the very best, and hope you have a very fruitful annual session. Thank you very much.